Ladies and gentlemen, welcome to Politics in the Pub and the discussion, Indigenous Australians. The gap is not closing. Why? My name is Joe Nagy, and I acknowledge the traditional owners of this land on which we are gathered tonight, the Gadigal people of the Eora Nation, and their leaders, past and present. We are privileged to have two expert speakers here. Andrew MEEHAN, National Director, Australians for Native Title and Reconciliation, and Dr. Tim Senior, a general practitioner at the Aboriginal Community Controlled Health Service. Now Tim Senior, he writes on general practice and social causes of ill health and a column on Croaky. That's not crikey, but Croaky, right?
Yeah.
Croaky, a blog that is a forum for debate and discussion about health issues and health defects of policy decisions. He won the Gavin Mooney Memorial Essay Prize for an article on the language used in climate change campaigning. He is the medical advisor in the Royal Australian College of General Practitioners, National Faculty of Aboriginal and Torres Strait Islanders Health. He is also a senior lecturer in Indigenous Health at the University of Western Sydney. He has previously worked as a medical educator and has practiced in Northern Territory, Thursday Island, as well as in the UK.
Hello, my name's Tim Senior, and I'm one of those strange people called a doctor. And I work at the Aboriginal Medical Service in Campbelltown. I'll say a little bit more about why that's important. But I sit in a room, and every 15 or 30 minutes or so, I see someone else come through my door with a range of problems. And that tends to be the focus that I take. It's very much seeing people with health problems and working with them to try and solve those health problems. And some of the things that come to light in that are things that you will all already know, and I think is the starting place for what I want to say, and that's what's the cause of people's ill health? And when we talk in politics about the health system or health policy, we're often talking about hospitals. And then if we're really lucky, we'll talk about primary care, and at the moment Medicare co-payments are a huge policy. If you wish, I can say more about that. But we rarely talk, and you can consider those to be sickness services, but we rarely talk about the sorts of things that keep people healthy and make people healthy. These are really well known in the health world, and we give them the rather clunky term, the social determinants of health. But essentially, the places that we live, the air that we breathe, the water that we drink, the schools that we're in, the jobs that we have, the food that we have, all determine what our health is. And so quite frequently I'll be sitting with someone who's unwell, and I'll say to them, look, really, your diet could be healthier, you know. And they go, yeah, I agree. But have you seen the price of fruit and veg? And you remember the Grocery Watch survey from a few years ago that they took down off the website? It showed that the most expensive fresh fruit and veg in Sydney was the northern suburbs, and the cheapest was the northern suburbs, and the most expensive was in Ayres, in Campbelltown, where I work. It was completely the wrong way around. And then if you go to remote and rural areas of Australia, I worked in a little town called Fink, Apatula, about 400 kilometres south of Alice Springs. The people who owned and ran the shop in that village, the only shop that sold everything, at one point moved away to another town, and the council took over the shop. There was no one to run it, they were doing other things. And so the shop was closed for much of the time, and we watched the children's weights go down. Nothing that we could do. And so the message is that there's so much more about the causes of people's ill health that is outside the health system. So the health system is really important, but what we call the social determinants of health need to be tackled if we're going to get anywhere with this. We often talk about Aboriginal health as if it's being Aboriginal that's the problem, and actually being Aboriginal and connected to culture is a protective factor. Some examples, I mean, even the terminology around Aboriginal, that's colonisers' terminology. Aboriginal people don't say, I'm Aboriginal, they say I'm Aranda, or I'm Dharawal, or I'm Pitjantjatjara. Because it's only when we come in and see this wide brown land and say this is one place that we can even start using the term Aboriginal and then throw in Torres Strait Islander as well. So the terminology tricks us into thinking that the problem is being Aboriginal. I'd urge you to go away and look at the Aboriginal map of Australia when you get home. Beautiful thing, covered in all sorts of different colours, no state lines. And it reminds me, coming from England, as if of Europe. And when we're talking about Aboriginal health, we're talking about, it's as if we're talking about Icelandic health and Polish health and German health and Spanish health and Portuguese health, if we were using the term European health. And it starts to lose some meaning then. And it tells us about the huge range in cultures across Australia, the different Aboriginal and Torres Strait Islander cultures that we have one word for. And we tend to group into one group of people. But you see this whole range of views as you would in any community, and it's important that we engage with that. The other important thing is what often happens with those statistics. Andrew was absolutely right about the statistics, and whenever I hear the statistics, I remind myself that a man called Paul Brodeur said, "Statistics are human beings with the tears wiped off." And it's absolutely right. It can fool us into thinking that these things are inevitable, that the problem is genetic. It isn't. 85% of genetic difference is between people in the same race. Another 8% of genetic difference is between people of the same race but different groups in it, like Latino and Romani. And only 7% of genetic difference is between people of different races. And almost none of that is responsible for health. So the differences that we're seeing, we're not looking at genetic predispositions to diseases. What we are looking at is the effect of poverty, the effect of inequality, the effect of dispossession and colonisation. And when you do that to human beings, those are the health effects that you see. And that's what we see in Aboriginal and Torres Strait Islander health. And so it's really important in tackling the problem, and one of the reasons that the gap isn't closing is that we haven't got to grips with that yet. We still have, we can still sometimes say, well, that's all in history, we should put it behind us. But no human beings put their history behind us. What would happen if we stopped celebrating Anzac Day in Australia? There'd be uproar. That's a long time ago. What would happen if we defaced war memorials? Uproar. But it's no different to celebrating Australia Day, which is offensive to many Aboriginal people. And so we can't just claim to put history behind us. The other thing we haven't come to grips with is what's called the intergenerational effects of colonisation. So if you think about something such as the stolen generation, who here cooks? Anyone do any cooking? A few hands going up. Who taught you to cook? For most people it was their mother. And who taught you where to get food from? Which bits of the supermarket to go to? Which butchers were good? How to test an avocado to see if it was ripe? If you're separated from your mother at a young age, all that knowledge about where to hunt, where to gather, how to prepare food, what the cultural ways of going about that are, is lost. So it's not just, oh yes, stolen generation happened in the past, it has very real effects for the children of people who were stolen and for their grandchildren. And that's just one example. You can think about the examples of that on learning how to parent, on being moved away from the traditional lands where you really know the plants, say in central desert Australia, down to Western Sydney with a completely different climate. So the impacts of that last a very long time, and we still see that happening today. The other major thing that I think we haven't got to grips with, and we're perhaps starting to, is the dreaded R word, racism. I'd urge you all to see the Beyond Blue campaign. Racism has demonstrable health effects. And we still hear too many stories of Aboriginal people turning up to health services and experiencing racism there, which in my book is like turning up to emergency and being given a packet of cigarettes. It's really unhealthy. We've heard about those health statistics and we know how much more common cardiovascular disease is in Aboriginal people, but an Aboriginal person turning up to an emergency department with chest pain from their heart is 22% less likely to get the appropriate treatment. An Aboriginal person turning up to an emergency department with symptoms of stroke is 3 times more likely to be dead or dependent on someone else at discharge. They're less likely to get an allied health assessment in a timely fashion. So this isn't just problems of people out there, this is people engaging with the health system that we know what to do. For me as a healthcare practitioner, that firmly puts the ball into our court, into saying, perhaps this isn't a problem of being you, perhaps this is something that we need to take some responsibility for. One of the things that we keep on doing is looking at Aboriginal people and saying, really, you just need to be a little bit more like us and everything will be fine. And that's not really a solution. We have to ask ourselves why 26% of Aboriginal people say they find it difficult to access healthcare. So a population that we know the statistics for, a population that we say this is a priority, and yet we've constructed a health system that 26%, a quarter of people can't access well. There's a whole range of reasons for that. Some of it is transport. Some of it is geography, not being near a service. Some of it is financial. People genuinely can't afford to pay even small amounts. Some of it is that you arrive at a health service and you're abused, or people assume you're drunk, or people turn you away and refuse to see you. And the effect of that is often to keep people away longer term. And some of it is that there's so much else going on in people's lives. I have children I need to look after, so I'll put my own health last. The house is in disrepair. I've got to get that sorted before I go and see healthcare providers. So there's multiple reasons for that, but the responsibility does come back to us as well. The solutions to that, we actually know. We know in healthcare, really quite convincingly, that that primary healthcare, multidisciplinary, holistic primary healthcare that focuses on the needs of people, actually protects people's health. It's been shown that if you employ more people in primary healthcare in a country, the health of the population gets better. And if we employ more people in secondary healthcare, the health of the population actually gets worse. People die more often if we employ more specialists. As a proud GP, I'm very fond of saying I'll let you observe where the power structures are in medicine. But we know that. In Australia, I would argue that the main place we see primary healthcare being done at its best is the Aboriginal community-controlled health sector. It's done pretty well in areas across Australia. General practice does pretty well, particularly where they really want to and they focus on it. Some areas don't do it quite so well, where it's focused on churning people through. But Aboriginal community control does it particularly well, and that's the sector I work in. I want to read to you the 2 definitions of health that you may or may not be familiar with. The one that health systems conventionally use is the WHO definition, which you may be familiar with, the World Health Organization. And they have a definition of health that goes, health is, health is a state of complete physical, mental and social well-being, not merely the absence of disease or infirmity. Rather beautiful. That's what health system conventionally sort of takes as its definition of health. Health is a state of complete physical, mental and social well-being and not merely the absence of disease or infirmity. Who can say that they're healthy on that definition right now? Marvellous. It makes me realise I've got a little bit of backache, I'm a little bit anxious, my mouth's dry, perhaps I'm not quite healthy. I'll read you the Aboriginal definition of health, which is the one used across Australia in all the Aboriginal community-controlled health services. Health is not just the physical well-being of an individual, but refers to the social, emotional and cultural well-being of the whole community, in which each individual is able to achieve their full potential as a human being, thereby bringing about the total well-being of their community. It is the whole of life view and includes the cyclical concept of life, death, life. You like that?
Yes.
I like that. Actually, I think we should adopt that for the health system overall. I think what Aboriginal people have done for us there is give us a human definition of health. Things that strike me, it's very social. You need to be connected to people in order to be healthy, and we all recognise that. And we recognise that in the rates of mental health and depression that we see. I saw an article the other day that argued that a lot of depression was purely related to loneliness. One of the common problems we see in general practice is people being lonely. It talks about people reaching their full potential, which I think is something that's really important in Aboriginal health. It includes death. How about that for a health definition? Rather nice. There's no mention at all of disease. So it strikes me that on the WHO definition you need to be completely disease-free and then have an added sprinkling of well-being in order to be healthy. But on the Aboriginal definition, you can have a disease, but as long as you're unable to reach your full potential in connection with community, then you can still be healthy. Aboriginal community controlled health services work to that definition, which is why they're incorrectly called Aboriginal medical services. So the whole structure is geared towards that definition. I'm employed there as a GP. It's not my service. So most GPs that you'll see, they own and run the practice. Sometimes another GP owns it and they're contracted there. But I'm employed there, and the community elect a board to decide the sorts of services that are right in that community. As a GP, if they don't like what I'm doing, they can sack me. It doesn't happen often. It has happened. And so I'm there and I provide medical services, I do prescriptions, I do the things that GPs conventionally do. There's good evidence that in Aboriginal medical services the patients are younger, as you'd expect. We deal with more problems in each consultation. Consultations are longer, and people see more health professionals in each consultation. So some of the services I have access to in-house are a financial counsellor. Centrelink come and do a visit. We have a community kitchen and a community garden. So think back to what I was saying earlier about the stolen generation and effects on being able to eat healthily. We do a subsidised fruit and vegetable box for people where they pay $15 to get a lovely big box of fruit and vegetables. And there's evidence from inland New South Wales that that has a really beneficial effect on people's risk factors for health. We have a childcare centre next door, and we have family services and family support for children, for families where they're at risk of not looking after their children. This all comes from the Aboriginal definition. If we want to be healthy, we need to enable people to reach their full potential. So we need to put those sorts of services around them. We often tell ourselves as non-Aboriginal people that this is a particularly difficult group of people to reach or a difficult group of people to work with and their health problems are really quite severe. But Aboriginal community controlled health services are getting just as good outcomes as mainstream general practice, and certainly better. In a population we tell ourselves is difficult. We're doing this on shoestring budgets. I mean, I was listening to Andrew talk, I was thinking about those cuts of say 120 million, 130 million. That's nothing. We've just devoted 600 million to increase security things. So the sums of money in terms of government are tiny for huge outcomes. And it's why one of the central things in Aboriginal Health Plan, particularly the Close the Gap campaign, which is led by Aboriginal people, is that Aboriginal people need to be leading this, they need to be in control. There are 150 Aboriginal community controlled services, maybe slightly more around the country, and each one of those is an example of a community saying, look, we know what we need, and this is how we're going to provide it, and with deep roots in the community. Health services are profoundly cultural institutions that sometimes, and they're built to our own cultures, and sometimes we can forget that they can be, there's usually not many people who like visiting hospital and feel at home there. They're usually only people like me who've been junior doctors. We've constructed a really complex health system that is really uncomfortable for people to come and visit.
And then we say, well, you should come more often to our health system. And actually the solution is staring at us. Aboriginal community control, and even in mainstream services, allowing Aboriginal people to have more say in the running of the services. And there are some models of where that's happened in government-run services and in private general practice. Produces services that people are happy to go to. There's a lovely bit of research from ANTaR that shows that asked Aboriginal and non-Aboriginal people about the cultural barriers to healthcare. And non-Aboriginal people talked about posters and pamphlets and policies and procedures, and Aboriginal people said that's fine, but it doesn't mean anything if we don't have a relationship with a person in the service. That is core. That's good primary health care, where people are able to provide care that that person needs over the long term. And we know that. That's not rocket science. It's not sexy. It doesn't often get soapy American TV series made about them, but it works. And it enables people to stop smoking. It enables people to turn their lives around. The story of Aboriginal health can look like it's all doom and gloom. But every day that I'm at the clinic, I see people who come in who are making enormous differences in their families and enormous differences in their communities. And that's happening across Australia. And they're doing it against the odds. They're doing it in circumstances that I'd really struggle with. And they keep going. And so I think one of the messages is just the sheer resilience of Aboriginal and Torres Strait Islander people. For over 200 years we've tried to tell them what to do, we've tried to gone through different policies of killing them off, leaving them giantly. It doesn't work. Keep on surviving. And if we are able to work with Aboriginal and Torres Strait Islander people and allow them to draw on those strengths, that's where the solutions are. I'm fully confident that the gap can be closed. Absolutely fully confident. But it does require us to do what Michael Marmot said. He was he's an English public health physician, was leading in the WHO on inequalities in health. And what he said, I think goes in for Aboriginal health as well, is that we need to enable, health arises from enabling people to live the lives they would choose to live. And that's our challenge. Thank you very much.